Окей. עוד פעם התנצלות ואנחנו מתחילים. אז פעם הקודמת, אז אנחנו בשיעור השני שלנו, ומה שעל פי סילבוס, השם של השיעור הזה יהיה Monoaminergic Theory of Depression and Schizophrenia. This is one of the slides that we stopped last time. We discussed that monoamines, they are very special because they play a key role in the mood regulation. And particularly serotonin is involved in obsession, compulsive behavior, in impulsivity, dopamine, reward, in motivation, and noradrenaline or norepinephrine. By the way, what the name is usually used by in Israel? Norepinephrine or noradrenaline? Both, yes. Norepinephrine is American and noradrenaline is European name. And also they work and create our mood. But today we will ask this question. It's not Hebrew, it's Aramaic, Mani Hani Milei. You know what does it mean? It's a very common question in Talmud. It asks, how do you know it? Why you so sure about it? And today we will start to go to the evidence on historical, a little bit on historical way, to check how exactly why monoaminergic theory of depression and schizophrenia seems to be valid. Discuss it, we will surprisingly, we will go first to not to speak about mood disorders, we will go to tuberculosis, shachefet. Some of you are some medical students here who is doing medical MD? No. It's start to be forgotten disease today, tuberculosis, because of the vaccination and improvement of the conditions of the life, this disease, but once it was a very bad disorder, very dangerous disorder, very deadly disorder. It's induced by gram-negative bacteria, Mycobacterium tuberculosis, and this bacteria induce very severe and very specific immune reaction with mostly not humoral, but mostly cellular immune reaction. It attracts macrophage and T cells, and they attract fibroblasts. It creates so-called granulomas or tuberculomas in the lung, which slowly can replace normal lung tissue, or if they located close to blood vessels, then it result in severe bleeding. And one of these conditions before treatments they existed was slowly bringing the patient to the death. And patients with tuberculosis 100 years ago, they were submitted to specific tuberculosis hospitals or tuberculosis wards, when they spend months, sometimes years, till their death. And it's obvious that people were pretty depressed in this place, in such places. What is actually depression? I reminded depression several times already, antidepressant. What is actually depression? Depression, it's not just low depressed mood. Depression is a chronic disease, a chronic disease of central nervous system. It has psychiatric mood symptoms such as decreased mood, anhedonia, anxiety, cognitive difficulties, feeling of guilt, feeling of worthlessness, and thinking about death. It can be with or without suicidal plans. Two first symptoms are mandatory in order the depression should be diagnosed, and three more symptoms out of this list must be present. But depression also has physical, some somatic, purely somatic symptoms, such as fatigue, headache, menstrual pains, and it's affecting 10 to 15% of males and 20 to 50% of females. And this considers to be second major reason for disability. You will be surprised, but depression even has mortality. And this mortality not necessarily from suicides, but depression also make worse the prognosis of comorbid regular disorders. If patient with depression, let's say, has also cardiovascular disorders with depression become much more bad, much more deadly. And depression continues to be one of the most costly disorders. It's 30% probably of healthcare cost in Europe. Depression can be caused by some physical illness, like what we just spoke just before a few minutes about depression and tuberculosis patients. Depression can be very frequent during and especially after the birth, but it can be induced by chronic and persistent stress, but it can be also appear without obvious reason. And we back a little bit to tuberculosis. This drug that you see on the left side is called isoniazid. Isoniazid is one of the first antibiotics which were used to treat tuberculosis. And it was discovered in 1912, and it was widely clinically used to treat patients with tuberculosis since end of 1940s. And what usually drug developers do, what usual pharmacologists do, we have some drug, it works, but its efficiency is far away from ideal. Let's create some chemical derivative, replace some group, replace some radical, and let's see, maybe it will work better. So pharmacists from Hoffman La Roche, from isoniazid, they created iproniazid, and iproniazid was also sold to hospitals, and physicians start to try to treat tuberculosis with iproniazid. And they found something very surprised. They found after patients that took it for a few weeks, iproniazid, they start to see disappearance of depression, and they start to significant improvement of in the mood. They were still sick with tuberculosis, they were still in the hospital, but patients become much more happy, much more interested in their life, much more active. And that's how the first antidepressant drug was discovered, which is very unique. Usually in all other medical sciences, we know the disorder, we know pathophysiology of the disorder, and we create medicine according to this pathophysiology. In depression, we have something very other way around. The first drug was discovered totally accidentally, and then we start to understand the mechanism of action and pathophysiology. This is this is how looks nerve terminal of monoamine neurons. As we spoke before, when action potential impulse of action potential, when they arrive to the nerve terminal, they make calcium channels open, calcium influxes into the cell, and through complex biochemical mechanism, which will now go through it, it makes synaptic vessels, which consist serotonin, noradrenaline, and dopamine, to fuse with a cell membrane and neurotransmitter release to the nerve terminal. What's happened with neurotransmitter after its release? It's got reabsorbed to the cell through special transporters. These transporters are specific to the neurotransmitter specific. Serotonin get reabsorbed by serotonin transporters. Noradrenaline get by noradrenaline transporter on NIT, and dopamine by dopamine transporter to DIT. Sorry, it was a small mistake. And what's happened with neurotransmitter after it gets reabsorbed to the cell? It has two options. It can be again reabsorbed to the synaptic vessels when reused, or it go to the process of metabolism, degradation of metabolism, and enzymes which are specialized on on metabolism of monoamines. It's called monoamine oxidase or MAO. Nothing to do with the Chinese leader. And MAO, they have two subtypes, MAO A and MAO B. MAO A is more specific. MAO A is can metabolize three of them: serotonin, noradrenaline, and dopamine, and MAO B or mostly specific to dopamine. And what we figure out what was doing this first antidepressant, is iproniazid. Somebody know? Exactly. It's actually blocked both of them, MAO A and MAO B. It blocks metabolism. By blocking metabolism, we get increase on monoamines in the nerve terminal, in the cell in general, and nerve terminal particularly, and we can increase in monoaminergic neurotransmission. The only problems with is actually MAO inhibitors. They still used some of them. They have many side effects. They're a little bit dangerous, but from the point of view of clinical efficiency, they still use as an etalon. Today we have MAO inhibitors. We have reversible, non-reversible, like the first one, isoniazid. He was not non-reversible, iproniazid, sorry. And lately, when you block MAO by non-reversible inhibitor, it's remained blocked forever, and new protein need to be synthesized in order that metabolism of monoamines will continue to work. And reversible monoamines, because they can be washed out and stop their action. There are some of them not specific for MAO A and MAO B, like phenelzine, but some of them are specific to MAO A or to MAO B. But what's wrong and what's the main side effect of MAO inhibitors? If you take MAO inhibitor and you consume food consisting of high level of tyrosine, such usually milk, cheese, so I should say other way around is very good and very healthy products. And if God forbid you consume beer, then you have high increase in blood pressure, which can be deadly. And somebody can tell me why you have increase in blood pressure after MAO inhibitors. What do you think?
It's like you have this synthesize more can process because of the MAO inhibitors.
Exactly. And what's wrong with if you have too much synthesis of catecholamines? Yes, catecholamines, exactly. And you saw tyrosine is a precursor of dopamine, noradrenaline, and adrenaline, how you say they so-called catecholamines. And we spoke till now about catecholamines in the central nervous system, but it's also very important neurotransmitter in the peripheral nervous system, and especially in the sympathetic branch of the autonomous nervous system. And it's released from terminals of sympathetic nerves, noradrenaline, and noradrenaline increase heart rate and induce vasoconstriction. And also in adrenal gland, it's released directly to the blood, to the circulation. Adrenal gland, it's some very interesting organ with synapse. It's like neural synapse on blood vessel. Instead of being released to another neuron, neurotransmitter get released straight to the circulation. And everybody knows that adrenaline released in medulla of the adrenal gland, but it's actually co-released adrenaline and noradrenaline. Both of them get released. And if you go, for example, to different species, predator species, they have monoadrenaline. And all this effect, if you have increase in catecholamines, you get increase in blood pressure. It's very important. I think maybe some of you will become drug developers. Somebody thinking about this career in the drug development, CNS drug development. And it's not correct to be too much focused on the central nervous system. You need to see general picture to see how things are working. They are working around. Another evidence for the involvement of monoamines in the mood came from different direction. It came from knowledge about the flower. This plant called Raufiola suprentina. Somebody heard about this plant and what does it do? It's very common in the Indian subcontinent, and Indian physicians for generation used this drug in very unrest and violent mad people. Because it's used if you give this drug, if you give substrate from this plant, it have very strong relaxation effect. Recently, about 100 years ago, active compound was found, and this active compound called reserpine. Reserpine has anti-hypertonic effect, what we saw before. Hypertonic effect has opposite effect, it decreases blood pressure. It has antipsychotic effect. It blocks hallucinations and delusions. We will speak a little bit later today about psychosis. But unfortunately, it has also depressogenic effect. It's induced very low and depressed mood. And how does it work? It would figure out that it blocks this one, the transporter, which transport monoamines to the synaptic vessels. When you have, it means that you may have even very high concentration of synaptic vessels in the nerve terminal, but nothing get to the synaptic vessels, and as a result, nothing get released. And despite in the tissue, if you analyze brain tissue, you will see normal, maybe even increased level of monoamines. De facto, we will have decrease in neurotransmission. And this decrease in neurotransmission results in this very sedative and antipsychotic, but unfortunately also depressogenic effect. And at this point, we already can see this yes. Excuse me? It's a very interesting question. To be honest, I don't know. Maybe it will induce some symptoms. Like I don't think it will be. It doesn't result in the death of dopaminergic neurons. It means that it will not induce Parkinsonism, but it may induce Parkinson-like symptoms, probably. Okay, so we now found two places when we can intervene in monoamine nerve terminal. It's metabolism and vesicular transport. Another place when we learn to successfully to intervene on monoaminergic neurotransmission, it's a reuptake blockade. We have two types of monoamine transporters. One is VMAT, vesicular monoamine transporter, which transport monoamines into the vesicles. And this transporter is non-specific. it's one of the, it's the same transporter for serotonin, noradrenaline, and dopamine. But we have another transporter which located on cell membrane, and it's transport a neurotransmitter after it's released to the synaptic shell back to the nerve terminal. And if we inhibit this reuptake, then we get more neurotransmitter in the synaptic cell, and we get more efficient neurotransmission. And who knows what was the first, which drug, which molecule was first discovered as a monoamine reuptake inhibitor? No, lithium doesn't, it's not, it's have different a little bit effect. It's cocaine. Yeah, cocaine, it's actually the triple serotonin, noradrenaline, and dopamine reuptake inhibitor. It's extracted from coca plants, from the leaves of the coca plants, coca bush, which is widely grows in the South America. It was used in South America, these coca leaves, they were consumed as a stimulant for generation. Indians used to mix it with, afar. The ashes, yes, thank you. And it was consumed and used as a stimulant, it's pretty strong stimulant. When Europeans came to America, they initially tried to prohibit it. A church was very against. They were sure that this plant is connected with devils, but they actively used Indians in the means to produce gold and silver, and then they will not work without these coca leaves, and they allow it to use it. Then Europeans also started to use it. It was very famous monastery in South America which produced wine. And this was a fantastic wine, with very strong stimulatory effect. And it was kept in secret. No one knows why this wine is like this, but it was also coca leaves were used in the process. Then initial Coca-Cola, original Coca-Cola was used in the coca leaves. It was extremely popular in the US during the Prohibition, because alcohol was very hard to obtain and it was totally legal. And this active compound, alkaloid cocaine, was isolated in 1859, and then trouble started, because unlike coca leaves, which they have a very strong concentration, and they're not that much dangerous. They were used historically, but probably, at least in Indian society, it never came to real drug abuse, and they still use, and this is a big discussion, because as a political discussion to destroy, not destroy coca plants. And who was Sigmund Freud? He was absolutely obsessed about cocaine. He was thinking that it's panacea, that you can treat everything, that is fantastic drugs without any negative effect, but with a fantastic antidepressant effect, with fantastic stimulatory effect. He used it himself. He described it to the patients. He published the Uber Cola in German and all cocaine papers in English. He published full monograph on this topic. And later he discovered that it has extremely strong addictive effect. And then he stopped to use it himself and to prescribe it. And what is actually wrong with cocaine? We know that we have other reuptake inhibitors. Why cocaine is so addictive? Because of the relative affinity to the transporters. You see that cocaine, mostly highest affinity to dopamine transporter, a little bit less to serotonin transporter, and much less to noradrenaline transporter. But if we take reuptake inhibitors, which used other reuptake inhibitors, which use antidepressant drugs, is other way around. They have higher affinity to serotonin, the average activity to noradrenaline, a very low activity to dopamine. We already, at this point, we already start to see that monoamines, they have different effects, they have different role in the mood. And with our drugs, we should be very careful which monoamine, which monoaminergic system we touch and to which degree. They thought because cocaine was unfortunately proven as a very abusive drug, it was not used anymore as a reuptake inhibitor to treat depression, but other reuptake inhibitors were developed, which other molecules, and first molecule to block serotonin, to block this monoaminergic transporters, they were so-called tricyclic antidepressants. Why are they tricyclics? Because they have three aromatic cycles in the structure. They discovered was influenced by knowledge about cocaine, but they were not synthesized from cocaine. They were discovered independently. Later in this class, we will see how pharmacologists came to their discovery of tricyclic antidepressants. And tricyclic antidepressants, they still used till today. They rarely use, but sometimes still use. They still pretty clinically effective. And we can divide them to three categories. Imipramine, it has relatively similar affinity to serotonergic and noradrenergic transporter. Some of them, like clomipramine, they more selective to serotonergic transporter. And some, like the zipramine, they much more selective to noradrenergic transporter. But all of them work as antidepressant drugs. And the question which was asked, which of monoaminergic system is more important in depression? What we should target first in the treatment of depression? And from our privileged knowledge on the drugs, we cannot answer this question because first known drugs, they were affecting all mostly serotonergic and noradrenergic, to less degree dopaminergic system, but all three monoaminergic system. And the answer to this question came from so-called depletion studies. What does it mean, depletion? Depletion, when we controlling food intake, and we try to deplete, to diminish synthesis of one of the specific, not synthesis, or diminish levels of one of the specific amino acids. For example, we already saw food which give us most tyrosine. It's like beef, salmon, milk, cheese, beans. They also food rich in tryptophan. It's also beef. It's also, for example, salmon. It's seeds, eggs. If we put somebody on the diet and excluding this food, then either levels of tryptophan or tyrosine go down, and as a result, we get decrease in synthesis of serotonin and noradrenaline. They are also the same, but there exist dietary recommendation. Delgado, it was a sign, I think he's still alive, and he published first, I would say it's a little bit ethically questionable the studies, but once you could do much more than you allow it to do today. He took patients which properly respond to antidepressant treatment. He gave and then patients were underwent either serotonin 5-HT depletion or noradrenaline depression. And we found that almost always after 5-HT depletion, if he had relapse of the same symptoms came back, of the symptoms of depression. But when noradrenergic depletion was applied, when tyrosine depletion was applied, then patients remained in remission. And this discovery was beginning of the serotonergic story of depression, which had huge influence on the subsequent drug discovery, because for many generations, subsequent pharmacologists, they focus mostly on the serotonin for the treatment of depression. Was it good or not? We still cannot answer this question. But after a few lectures, you will understand pro and contra. Should we focus on serotonin or we should not focus on serotonin? What is very interesting with serotonin depletion, it works not only in humans, it also works in animals. If you put rats or mice on a diet without tryptophan, you start to see depression-like behavior. You cannot say that you have depressed. Sometimes I see it in the papers, but it's not true. When we have depressed rat. Depression, per definition, is a human disorder. But it can be depressive-like behavior in animals. And how do we measure depressive-like behavior? I think some of you working in behavioral neuroscience. Yeah? No? You have heard about behavior tests? Yes. There's three key, but you do work in behavioral neuroscience, yeah, what I asked. There's three main tests for depressive-like behavior. It's a sucrose preference test, which measure anhedonia. It's elevated plus MACE test, which measure anxiety. And it's for swim test, we designated to measure the level of motivation or depression per se, sometimes it's called. Who of you know how it works? All of them, or one of them at least.
So the preference test is based on if you want to test anhedonia or not. So if one can enjoy like sugar, they will prefer sweet water. But if it's subject to anhedonia, it will have music.
Yeah, exactly. Rats, they like sweet very much. So if you put sweet water, they will consume it a lot, even more than they usually drink. And by rats with or mice with depressive-like symptoms will not have preference, will not have that much significant preference. How are you doing APM, elevated plus MACE?
Elevated drug. So it's anxiety tests. Mainly, mice enjoy enclosed spaces, but they are curious animals. So whenever you give them a new environment, they're going to shut it out. More anxious mice will stay in the closed arms instead of the open arms. We do it in what is called an elevated zero gauge, which is the same way as you, as two open to closed arms, but it's in a circle instead of a plus.
There's some exactly same with rats. I work with rats mostly, and rats also they prefer closed places, but because of the curiosity, they go to open places as well to investigate them. And as much as rat as a rodent is anxious, as much he will prefer closed space. And finally, we have For swim test, somebody is doing it. No, no one is doing for swim test. For swim test, it has unfortunately it has very bad reputation now, and it might become prohibited in Europe, and this unfortunately because of misunderstanding. Unfortunately, for example, Yuval Harari, whom I like, by the way, I read his books, but he contributed to this misunderstanding. He's one of his lectures that researcher put for a full day rats or mice to swim in the water, but it's not true. That all duration of the test in 10 minutes, 5 to 10 minutes, and animal cannot be harmed. It's of course it's not nice experience. Of course, it's a very anxious and stressful experience, but rat cannot be harmed and cannot drown during this time. You put rat or mice, you put the cylinder with water, and rat can show three behaviors during the. Rats can float immobile on the water. Their body because they have many fat tissues, they can without more, unlike us on water, they can float on the water for a long time without movement, and by such they like preserve the energy, preserve the force. They can swim. They usually swim around the cylinder. I think next I have to bring you video. I will do it next time. And another type of the behavior is climbing on the wall. Rat is try to climb on the walls, trying to get out. And what you think, which behavior is more depressive like, and in which is opposite to depression? Exactly. Mobility time, as long as the mobility time, as more rat is depressed. As more rat show swimming or climbing, it's behaviors which are opposite to depressive behavior, which animals try to do something to get out of this despair situation. And there's third behavior, but no one still measure it. But I was thinking them to start to measure it. Some rats even dive to the bottom of the cylinder and trying to find way out. And we will see later that both of the swimming and climbing. Swimming is the more serotonergic-like behavior, and climbing is more noradrenergic-like behavior. And if you induce rats, there are plenty of studies about it. If you put rats on tryptophan depletion, then you will have less sucrose preference. Then they'll spend much more. They will be much more anxious. They will spend more time in the closed arms, and they will be much more immobile, much more high immobile time and less swimming and climbing time. And it means that we have animal model of depression. And one of the first animals, there are plenty of models of depression, behavior, biochemical. We will remind maybe them later. But I myself like more this model out of all other models because this is the only model with a translational model. With the same procedure induced depression symptoms as well in humans as well as animals. Okay, because of this finding, it was hypothesized that 5-HT play, even if other neurotransmitter also involved in depression, 5-HT might play a key role. Do you like to make break or to continue? To continue, okay. And this knowledge about eligibly key role of serotonin in depression contributed to the discovery of the second generation antidepressant drugs, which were called selective serotonin reuptake inhibitors. as they called, their name means that they selective inhibit, unlike tricyclic antidepressants, they were very selective inhibitors of the serotonin transporter. They almost do not touch other transporters, but still they have different level of selectivity to serotonergic transporter. First SSRIs like fluoxetine, or well-known Prozac or paroxetine, in addition to serotonergic transporters, they also targeted some receptors. And the most selective 5-HT reuptake inhibitor is called citalopram. It was fluoxetine, paroxetine, they also target some receptors like 5-HT2A, 5-HT2C. We will talk about receptors a little bit later. And citalopram, who was synthesized in the 90s, it's more very potent, very selective to the serotonergic transporter. It almost does not touch any other receptors in the cell. But what's very interesting with citalopram, it has two optical enantiomers. You all know stereochemistry. You know that by some organic molecules they have optic enantiomers. And as citalopram, they have R-citalopram, or right optic enantiomer, and they have also, in the beginning was called also citalopram, but later it gets them S-citalopram, like written here. And from pharmacological point of view, they are totally different molecules. They're absolutely different. The effect not only different, the effect on serotonin reuptake inhibition is opposite. How can you check effect of some biological, of some organic molecule, of some drug on the release of the neurotransmitter? There is a techniques, it's called microdialysis, in vivo microdialysis. Somebody heard about microdialysis? Yes? You doing it? No? I did my master degree and then all my PhD. It's very hard work. You take a membrane probe with a semi-permeable membrane. You insert rat or mice being anesthetized. You implant this probe to the brain region which you're interested in. If you work with serotonergic system, you can be interested in rough nucleus. And you perfuse this probe with a solution with a unique composition close to the cerebrospinal fluid. And then biological molecules, the membrane is semi-permeable, it's permeable only for relatively small molecules, to amino acids, monoamines, maybe sometimes to small peptides. And by diffusion, they come to the solution, solution being perfusion solution. And by this method, you can measure the concentration of the molecules, specific biological molecules in the specific area of the brain. This study was done by Merck. It's scientist in Lundbeck, in the pharmaceutical company Lundbeck. He did this study in 2003, and he compared the effect of citalopram, S-citalopram, and R-citalopram. Rats anesthetized, probe being inserted into the brain, and then rat get injection of one of the three compounds. And what you see, when a rat injected with R-citalopram, it has absolutely no effect on extracellular serotonin levels. It means that R-citalopram has no interaction with, no, it has interaction, but it does not block serotonin transporter. If you inject if you inject rat 4 milligram of escitalopram, you get something about 40% of increase in extracellular serotonin. But if you inject 2 milligram of escitalopram, but depending on if you inject 4 milligram of escitalopram. How much in escitalopram and 4 milligram of escitalopram? 2 milligram. So what do you expect? You will expect to see same reaction. If escitalopram doesn't work and only escitalopram is working, then if you inject 4 milligram of escitalopram, should be equal to 2 milligram of escitalopram, but it was not true pharmacologically. It's escitalopram not only doesn't block reuptake inhibitors, it also prevents escitalopram from working on its full mode of efficiency. And later it was discovered why it is so. On the reuptake side, on this reuptake side, we have two actually binding sites for SSRIs. One is the main site and one is allosteric site. And when escitalopram builds to allosteric site, it prevents escitalopram from to build to the main working site of the transporter. It's this topic of stereochemistry of the drugs, of CNS drugs, was neglected for the first time, but we now see that this topic is very, very critical. Okay, till now we saw several points of intervention. We saw that we can intervene on the level of metabolism. We can intervene on the level of vesicular monoamine transporter. We can intervene on the level of membranal monoamine transporter. Where else you think we can intervene in the treatment of mood mental disorders? Excuse me? Exactly. We can also intervene on calcium channels. They are ideas, but it's too much dangerous because it will work everywhere. First drugs to work directly on the first drugs which work directly on the transporter, on the receptors, they were not antidepressants, they were antipsychotic drugs. We have three receptors, types of receptors which regulate neurotransmitter release. Actually, we have more, but we will see it soon. On nerve terminals of serotonergic neurons, we have receptor 5-HT1B. On the nerve terminals of dopaminergic receptor, we have receptor T2. And on the nerve terminal of noradrenergic receptor, we have alpha-2 adrenergic receptors. And activation of these receptors results in decrease in neurotransmitter release. So what will happen if we will block is if we will block them, then we will get increase in technically we're supposed to get increase in release of neurotransmitters. How first antidepressant drugs were discovered? It was again same with antidepressants. It was coincidence. First let's speak about what is psychotic disorders. Technically, all mental disorders are divided into two categories, CNS disorders, to mood disorders and psychotic disorders. Initially, it was believed that mood disorder is a disorder of the mood and psychotic disorder is a disorder of the souls. But today we know that it's not the case because either all mood and cognition and the soul, they disturb in both types of disorders. But mood disorders, we know it's what we know, which mood disorder we know it's a depression, anxiety, panic disorder, obsessive compulsive disorder, and post-traumatic stress disorder. And psychotic disorders, it can be either acute psychosis. Acute psychosis can be endogenous or exogenous. It can be induced by some kind of reason, and one of the reasons we will see soon. Or schizophrenia, it's a chronic endogenous psychotic disorder. What is schizophrenia? Schizophrenia is a disease which is characterized by two blocks of symptoms. One block is called positive symptoms and one called negative symptoms. Positive symptoms, they present only on the time of psychotic episode. When patients successfully managed with antipsychotic drugs, it does not show, he or she does not show positive symptoms. And positive symptoms are delusion, hallucinations, disorganized speech and thinking, and disorganized or usually agitated behavior. And negative symptoms, it's persistent decrease in social interaction, social function, and cognition. And as I told, the positive symptoms, they present during the psychotic episode, and negative symptoms, they persist forever, unfortunately. And as much from episode to episode, as much disease is progressing, negative symptoms getting worse and worse. And first antipsychotic drugs was chlorpromazine. It was discovered in 1951, pretty simultaneous with antidepressants, with the first antidepressants. And it was a derivative of another drug, or promethazine. And promethazine was actually antihistaminergic drug. It was initially not intended to treat schizophrenia or psychosis. Schizophrenia at this time was treatable disease and a totally untreatable disease. Well, electroconvulsive shocks, which were used, which still used. Also at this time, pretty barbaric treatment like insulin shock was used, and to inject to patient insulin to cause the hypoglycemia, to put him into the coma. It's also helped. But it's of course not very recommended way of treatment. And how the chlorpromazine was discovered? It was discovered not by psychiatrists. Is antidepressant discovered by physicians who treat tuberculosis. Chlorpromazine was discovered by very famous French surgeon. Can Laborit, somebody know how to pronounce French names correctly? Henry Laborit. He used chlorpromazine, he administered chlorpromazine as antihistaminergic drug to patients with severe burns. And patients with severe burns, because of the toxic and pain shock, they have sometimes psychotic issues. It's not schizophrenia, it's exogenous psychosis, but they can hallucinate, they can be totally disorganized. And suddenly he found that chlorpromazine reduce these psychotic effects. Yes. Well, patients with burns, they may have psychosis. They can hallucinate, and can be delicious, but it's because of the pain, because of the toxic shock. There are plenty of. No. Other way around. When he administered chlorpromazine to this patient, they stop to hallucinate. They get much more relaxed, and they mentally feel better. Well, I don't think it has a pain-killing effect. Maybe some because of noradrenergic. No, I'm not sure. And this drug, first antipsychotic drug, phenothiazines, they actually worked on all these three types of receptors, mostly on T2 receptors, but partially on 5-HT1B and alpha-2 receptors. And they were pretty okay from the point of view of efficiency, but they were also very dangerous. And they were dangerous from the same reason like first antidepressants. Actually, they are very similar. And first antidepressants, they were also independently, but they also produced from antihistaminergic drugs. So it was simultaneous discovery two simultaneous discovered two very similar drugs, which is very interesting. Second generation of antipsychotic drugs were discovered. These drugs were synthesized in order to increase safety and to decrease their side effect. And haloperidol is one of these drugs, of the second generation drug, and is a very well-known drug. It's still one of the most used antipsychotic drug. Another one example, benzpridol, which is considered to be the most efficient, but most efficient in terms of positive symptoms. And what is the mechanism of action of this second generation butyrphenones? They act mostly on D2 receptors. They almost have no affinity to serotonergic and noradrenergic receptors. And what about the clinical efficiency? The clinical efficiency. The first generation antipsychotic drugs like chlorpromazine, they have very poor safety, but they have good efficiency against positive symptoms, and they have also some efficiency against negative symptoms. And their mechanism of action, they told it T2, 5-HT1B, 5-HT2A antagonism. The second generation antipsychotic drugs like haloperidol, it has much better safety, still not ideal, but much better safety. It has very good efficiency to the positive symptoms, but it has absolutely no effect on negative symptoms. And it works as a D2 antagonist. And finally, with this third generation of antidepressant drugs, we will talk about them on not to the next class, but the class after the next class. And with them, we have something interesting. They have very good safety. They have very good effect on positive as well as negative symptoms. And they work on D2, alpha 2, and 5-HT2A and 5-HT2A serotonergic receptors. What does it say to us? It says to us that positive and negative symptoms of schizophrenia, or possibly they have different pharmacological basis. And if you treat successfully these two clusters of symptoms, you need to activate different mechanisms in the brain. And later we will see not only psychosis, not only schizophrenia, depression. Different symptoms of depression may also have very different pharmacological basis. And with this, I wanted to finish the second lecture. Let's have question and discussion. We still have time. Yes.
Slide
32. Yes.
I don't really understand what effect are and then
Okay, this is the basal level. We collect fraction in microdialysis. We collect this dialysate and measure level of neurotransmitter in this dialysate. We must, before to start to measure some kind of effects, we must to take several fractions as a baseline, usually at least 1 hour. If we see here this as 1, 2, 3, 4, is a 5 basal fractions, and this is concentrate, and this is a concentration of neurotransmitter during this basal. Then we inject to the red the drug. We inject SSRI, and if it's a reuptake inhibitor, what we expect to see? We expect to see increase in serotonin. But as I told, this they have two enantiomers, citalopram, escitalopram, and arcitalopram. And the aim of this research was to compare them. Citalopram is a right optical enantiomer of citalopram, and escitalopram is the left optical enantiomer of citalopram. Many biological molecules, they have a mixture of two optical enantiomers. They both. Regular citalopram is called racemic citalopram. It has 50% left, 50% right. And here we Merck compared their effect. When he injected R citalopram, the pure R enantiomer, it had no effect. Okay, it means that right racemic, that right enantiomer does not block reuptake site. When he injected the left one, pure left enantiomer, he get increase in from 10, I think, femtomolar till 40, 400% of increase. It means that left enantiomer successfully blocks reuptake site, okay? And he took 4 milligram of citalopram. Citalopram is 50% left, 50% right. In 4 milligram of citalopram, how much is citalopram? What you will expect the same reaction for 400% of inhibition of increase in serotonin. But he get only about 300%. It means that that right enantiomer not only block reuptake inhibition, but it also prevents S enantiomer from full potent of action. And because this happens because there are two bindings, main binding site and allosteric binding site. Zamovan, can
The S.
how?
How to write the function of the S?
Yes, because of two binding sites. If R bind on one of them, it prevents S from the action. עוד שאלות? יש לנו כמה דקות, רוצים להתחיל חדש? כן? בואו רק נתחיל. הנושא הבא שלנו זה יהיה auto-regulation of monoaminergic neurotransmission, the role in and its role in antidepressant drugs response. We will just, in a few minutes that we still have, we will just start this new topic and we will continue the next week. We are coming back to our monoaminer terminal. We see that we have 4 places of intervention, but we don't intervene on the level of vesicular monoamine transporter because even it has some antipsychotics effect, it also induced depression. We can intervene on on the level of metabolism, and to increase the level of monoamines, we can intervene on the level of transporter, or we can intervene on the level of serotonergic receptors. We already saw this slide, we discuss it now. When we inject escitalopram or citalopram and we get increase in serotonin, how long it takes to get increase in serotonin? Even less, but we start to see in 20 minutes because it's just next fraction. We don't know what's happened here because of that. But we use more delicate methods like voltammetry. We see even in few seconds we see it already. And how you think when we will see the clinical effect, when patient will start to feel better. And yes, exactly what we see here. This is a clinical study with the same drug, with escitalopram. To see the drug has a an effect, what we use a double-blind study. We compare it with a placebo. In this study, 50%, 189 patients received placebo, and 191 patients received escitalopram. And when you start to see any difference between placebo and escitalopram after 2 weeks. So it was patients, they were still depressed, they were still not in remission, but some first initial effect you don't see earlier than in 2 weeks. And somebody can tell me why, what's going on, why you have increase in serotonin immediately, and you have clinical effect after such a long time. Yes. Yes. It means that so many adaptive changes must happen in the brain, in the CNS before we see effect. And one of the first adaptive changes, it's activity of autoreceptors. We can discover, it was to see it, we need to use another method. And this method is called electrophysiology. It's method that I am working on. You also understand, you also stereotaxic techniques, and you also insert electrode, you insert in this time, you said not microdialysis probe, you insert electrode, again, into the specific brain area. And on this electrode, you detect action potential which is generated by spontaneously active neurons. And this one experiment from my lab, it's I was not first to do this specific experiment, but in one of my experiments, I had to repeat it, to replicate it. We injected electrode to the dorsal nucleus where serotonergic neurons located. We recorded the activity of neuron, and then we injected as a selective serotonin reuptake inhibitor. Let's see what's going on. This is the basal activity of the neuron. You can see and you can hear the action potential. And this is the same neuron after we injected escitalopram to it. What is the effect? What do you think? Yes, and the firing activity. What's happening with the firing activity? It increased, decreased? decreased. You see here, yeah, this is a graph of one of my papers. We inject escitalopram and we get decrease in the firing activity. And what's going on? We learned that escitalopram should increase the serotonergic neurotransmission. And now we see that when you inject them, you have decrease in serotonergic neuronal firing activity. And if you have decrease in the firing activity, you have decrease in neurotransmission. And indeed, not only after acute effect, if we inject escitalopram to animal, we treat animal with a rat with escitalopram for 2 days, and control animals treated with a saline, we see after 2 days still strong decrease in the firing activity of serotonergic neurons. And when we treat animals for 14 days, we have this decrease disappears. This is probably one of the first key changes, key adaptive changes, which we need to see clinical effect of antidepressants. And if we go back to this clinical study, you also see that after 2 weeks, you start to see the clinical effect. And why you think this inhibition happens, and why does it disappear? It activates autoreceptor. There are 2 autoreceptors. Last time we spoke about this blue one is 5-HT1B autoreceptor, which expressed in the nerve terminals. There is another autoreceptor which regulate serotonergic transmission. We will come back to this next class. Is 5-HT1A autoreceptor. And they have similar effect on serotonergic neurotransmission. This 5-HT1A autoreceptor and 5-HT1B autoreceptor, both of them decrease the serotonin release, but they do it in different mechanisms. 5-HT1A autoreceptor down-regulates the firing of neuron, and 5-HT1B autoreceptor decrease the neurotransmitter release on nerve terminal level without to change its firing activity. And that's what you see here. When you inject escitalopram, we have first decrease in the firing activity of the neuron, but then if we administer specific antagonist of 5-HT1A autoreceptor, the firing activity of the neuron recovers. So probably what's happened after what you think happened after 14 days with this receptor? Yes, this receptor desensitizes because we have because it's free, we have a lot of extracellular serotonin. It's frequently activated and it's desensitized. It's one of the explanations why we have this prolonged effect, that when we have acute activation, acute increase in serotonin in nerve terminals, we have activation of 5-HT1A1B receptor, we have decrease in the firing rate, and the result on the level of nerve terminal, we don't get more serotonin than it was at the beginning. And we need this desensitization first, desensitize 5-HT1A autoreceptor nerve terminal, and then after 2 weeks, we have desensitization of 5-HT1B autoreceptor. Okay, I suggest we will stop today here, and we will continue on this autoregulation next time. Any question now about autoregulation? This one? We will speak about this next time on lunch, but in general, because we have increase in extracellular serotonin, we can activation of autoreceptors, and we can decrease in the firing activity. And because of the decrease of the firing activity, we don't get more serotonin than it was at the beginning. And we need to change to the adaptive changes or to desensitization of the receptor. I would like to discuss something with you. I have one idea, actually, my postdoc and my PhD students suggest me. Would you like to have one class interactive visit in my lab? What do you think about it? To try. Some of you sensitive to animal experiments? No? Okay, we will. I have place, I sit in the... Okay, אני אעצור ריקורדינג, ואנחנו יכולים לדבר עברית. So